All right, I'm seeing the attendees list starting to plateau, so I'm going to go ahead and get started. Welcome, everyone. My name is Christine Petrin. I'm a MedPeds primary care physician in New York City and East Harlem, and I'm also the president of Doctors for America, and I'm so excited to welcome everyone to our September Advocacy Grand Rounds event. Before we get started, I just wanted to take a quick minute to invite you to officially join Doctors for America if you haven't already. We are a movement of over 40,000 doctors and medical students across the country who have come together since 2009 to ensure that everyone has access to equitable, affordable, and high-quality healthcare and the opportunity to lead a healthy life and live in a healthy community. Becoming a DFA member is really easy. You just go to the link in the chat that our wonderful DFA staff is gonna send right now. And if you click that link, you can support DFA's work in programs like this, our Advocacy Grand Round series, and learn about other ways to get involved with our organization. One quick disclaimer, we are live streaming this presentation on Facebook Live, and we're recording it as well. So all the materials will be available for you afterwards. There's a couple of quick ground rules for our session today. One is we welcome your questions. If you have a question, you can put it in the Q&A chat, and we'll go through some audience questions a little bit later on. So you use that Q&A feature, and then we'll address those as the meeting progresses. And then also be on the lookout in the chat. Our DFA staff is going to be sharing helpful links throughout the session that relate to what we're talking about, and at the end kind of help wrap everything up. So with all of those logistics being said, we're going to move on to our speaker. I'm so thrilled to welcome Dr. Dave Choksi. He is a physician and public health leader who served as the 43rd commissioner of my city, New York City, Department of Health and Mental Hygiene. During his tenure, he led New York City's response to the COVID-19 pandemic, including its historic vaccination campaign, testing and treatment strategy, and reopening efforts, saving tens of thousands of lives. He also launched major public health initiatives, including the nation's first publicly authorized overdose prevention centers and a landmark Board of Health resolution declaring racism a public health crisis. He currently serves as the Sternberg Family Professor of Leadership at the Colin Powell School for Civic and Global Leadership at City College. He is also chair of the Common Health Coalition and co-chair of the Health and Political Economy Project, two initiatives that we're going to be talking about during our discussion today. From 2014 to 2020, he held leadership roles at New York's health and hospitals, including as its inaugural Chief Population Health Officer and CEO of its Accountable Care organization, which achieved high-quality, cost-effective care for over a decade. He previously served as a White House Fellow and Principal Health Advisor in the Office of the Secretary in the U.S. Department of Veteran Affairs, and he practices primary care at Bellevue Hospital, and is a professor at City College in New York. He is a Rhodes Scholar, a graduate of Duke and the University of Oxford, and earned his MD from the University of Pennsylvania. So with all of that, let's go ahead and get into our discussion. Dr. Choksi, thank you so much for being here today.
Thank you, Catherine. Thank you. And please call me Dave, and if you'll allow me, I'll call you Christine as well.
That's just what I was about to say. Perfect. Okay, so I want to start actually with I want to ask you about an article that you just published in Stat about a month ago, last month, that details a lot of confusion around seasonal vaccines. So as we're approaching cold and flu season, a lot of us are seeing this in our clinics now. You describe how federal policy and access barriers have limited the uptake of vaccines like RSV and flu, despite their availability. So walk us through what we're seeing on a national scale when it comes to seasonal vaccines, and what specific strategies, either at the state, community, or even at the practice level, that we can all engage with that can improve that uptake.
Yeah, well, first of all, thank you so much for having me. I'm really looking forward to this conversation. Thank you to Doctors for America, not just for having Advocacy Grand Rounds and inviting me, but for all of the really vital work that you do every day. I can't imagine a more consequential moment for those of us who care deeply about health to think in the broadest terms possible about how we can preserve and protect the health of the patients and the communities that we serve. So very genuine thanks for that. And that's a segue to this work that I've had the privilege of being involved with around seasonal vaccines, also known as respiratory virus vaccines. I know, all of the folks who are on this call will be familiar with it, but it's influenza, COVID-19, and RSV immunizations, which uh, those three diseases taken together claim more lives by the end of winter than all other infectious diseases combined in the United States. This is a really important thing for us to hold on to. And I know you all have seen it in your own clinical practices, as I have. Not just the folks that we worry the most about, older individuals, people who are immunocompromised, the young babies, who suffer from the worst outcomes from RSV. But there's also likely a case that is stuck in your memory about a patient who was previously healthy, sometimes young, and was laid low by flu or COVID or RSV in a way that in this day and age is now largely preventable because we do have these great immunizations. And I do think it's worth us reflecting on the fact that this is progress that is not to be taken for granted. I mean, certainly for me, in my experience with COVID-19, I remember those dark and devastating days of March and April of 2020 and how much we wished for a vaccine to be able to avert, all of the suffering that we saw. But on a larger time scale, when I was a medical student, we didn't have immunizations for RSV. I remember one of my first, rotations in medical school was at the Children's Hospital of Philadelphia, and seeing, babies nostrils flaring, struggling to breathe, and realizing that we now have the chance to prevent so much of that is, I think, where we should be grounded in understanding the gravity and the urgency of what needs to happen. And look, it's not easy in any respiratory virus season, right? Even last year or the year before, when we had sort of the normal, quote unquote, normal, FDA and CDC processes playing out, we still had our work cut out for us to ensure that as many patients got vaccinated as possible. But that has become even more of an uphill battle because of some of the confusion around, federal vaccine policy changes. And so, that this is the piece that you alluded to that I wrote sort of with my hat on as chair of the Common Health Coalition, which has been organizing quite a bit to ensure that we clear up as much of that confusion as possible. And we spread the word that, if there's confusion around federal guidance, then the rest of our health system really needs to be able to fill in some of those gaps. And so what we've done, the Common Health Coalition, which I'm happy to share a little bit more about, but, we represent different sectors of the health system and essentially try to dissolve the silos among them, as much as possible, not just doctors and hospitals, but also health plans and public health organizations toward, our common goal of health, as it were. And so what we did for respiratory virus season is to create some scenario planning toolkits, and other ways for people to sift through exactly what's happening. So from the payer perspective, making it very clear how important coverage without cost sharing is, particularly for these three immunizations. From the provider perspective, particularly because of the FDA label change around COVID-19 vaccines, speaking to some of the concerns about provider liability in administering them. And then from the state perspective, making it clear what the state actions can be to, for example, preserve pharmacists' ability to vaccinate, for COVID-19 and the other immunizations as well. So let me just try to summarize very briefly, sort of where we stand right now, because ACIP happened last week, of course, and the upshot is more promising than I had feared at least a month ago after the FDA label change, because the ACIP did, essentially uphold the ability for anyone 6 months and older to be able to receive a COVID-19 vaccine with shared decision making. And then the health plans came out with a statement last week signaling their intent to cover vaccines without cost sharing as well. So let me take a beat there because I know I said a lot.
No, that was fantastic, and it led into multiple of my next questions, which is great because I the next thing I want to talk about was ACIP and DFA. Our members have been very vocal about opposing the removal of expert voices from advisory roles, and we've been very concerned about how this impacts public trust in vaccines. You've emphasized the importance of radical listening and like how providers can partner better with members of their community and local leaders to try to dispel or at least help correct some of that trust and bring it back. I think you were leading into this a little bit, but can you talk a little bit more about what opportunities there are for physicians to try to do that kind of work on the ground?
Yeah. I mean, it's critically important, again, in any season and for all vaccines, but particularly now, and particularly ahead of respiratory virus season. We know from very well-established evidence that a provider, a clinician's recommendation to vaccinate is among the very top factors as to whether or not a patient chooses to get vaccinated. Again, you all know this from your own practices, so I know you have your own experiences with it. But I think about how these conversations play out in my own exam room, and um, it just takes time. It takes listening and sort of nodding thoughtfully when you hear about all of the different ways that people are wrapping their brains around, the confusing information environment that we're in. But at the end of it all, there is that moment when you look into your patient's eyes and you realize whether or not you have a relationship such that they're going to trust you. And so often that is what, sort of brings it over the edge for someone who maybe had some doubts about getting vaccinated, but then chooses to really because they fundamentally believe that you care about them and are looking out for their health. So, and it's just concentric circles out from there. In the human encounter that we have the privilege of having as doctors. But then it's about, okay, how do we bring that to the community level? And as you all know, it's not solely about doctors, of course. I'm a big believer in community health workers. I'm very proud, Christine, and in terms of our efforts for the COVID-19 vaccination campaign, that as part of that, we invested the largest amount of public funding by a city in the United States ever to support community health workers around COVID-19 vaccination. And then, beyond our communities to the medical societies that we have access to, state governments who, listen to physicians, and then, some of the advocacy work that DFA and other groups are doing at the national level as well. But it all starts in that moment of building trust through listening, through having relationships that accumulate over time. And then also for us to have the humility to know when it is that we as doctors should take a step back and empower others, whether it's CHWs who often have a greater lived experience, with the patients that we're serving than we do, or other messengers like faith leaders, leaders of community-based organizations, and others who have the currency of trust that has been built up over decades in the places where they are.
Yeah, that's such a great point. Especially now thinking about it, with every patient I'm seeing now, moving into this season. And yeah, the one thing I loved about your article, and you shared a little bit about it just now, this is again referring to the STAT article from last month, is that patient interaction that you had, that remembering your first patient with RSV and what it's like to watch that for the first time. It triggered the same kind of emotions and memories for me of what it was like the first time I was in the pediatric emergency department and had my first brush with RSV, and seeing that from a patient level. So I encourage everyone to take a look at that article if you haven't already. So let's shift. You mentioned the Community Health Coalition already. Let's shift to your ongoing work there, and also with Health and Political Economy Project. You've shared a little bit about Common Health Coalition, but can you kind of broadly share what these two initiatives are, and how specifically your work with them both reflects like your broader vision for equity within our healthcare system?
Sure. Well, I'll start actually by just sharing. And behind me here, you may not be able to see it that well, but I have a whiteboard, and I've had a whiteboard in every single office, that I've had over the last 15 years or so. And I always have sort of three columns: short, medium, and long. And that is to help me remember that the things that feel urgent to me are not always the most important things. And so even as I have my daily to-do list that goes in that short column, I'll have my weeks to months list, that goes in the medium column, and then my years long, goals or objectives that goes in the long, side of the equation. And that's really how I think about this work with the Common Health Coalition, as well as the Health and Political Economy Project, where the coalition is really like what we should have been doing yesterday, to be able to knit together the different sectors that I mentioned. The coalition started as a collaboration with 5 major national healthcare organizations: the AMA, the American Hospital Association, AHIP, and ACHP, which is two of the health plan groups, and then Kaiser Permanente, who, in the wake of the COVID-19 pandemic, where we saw both sides of the coin, we saw how fragmentation makes our jobs much more challenging, but we also saw the promise when those sectors were able to work together toward a public health goal. The way that I think about it is there's just no way that we would have been able to vaccinate 6 million New Yorkers in a little bit over a year from just the health department that I had the privilege of leading. It relied on doctors and pharmacists, but also, payers making certain decisions about coverage. And so, those 5 organizations got together. This was in 2023, and said, this should really be business as usual. This shouldn't just be something that we build in times of a crisis. In fact, it's more important to build it during peacetime so that we're able to, respond in times of crisis. And so since we started with those 5 founding organizations, we've now grown to over 350 organizations across 45 states. Thank you for putting the links in the chat. We welcome organizations to join the coalition after folks join DFA as well. But this is a chance for us to knit together both at a national level, but then at a local level as well, those partnerships across sectors. And now that we have sort of, a big tent established for this, we've undertaken, some more tangible projects across the coalition members. So I mentioned the respiratory virus vaccination efforts that we have undertaken in the last few weeks and months. We also earlier this year launched something called the Common Health Challenge, which will be an annual kind of call to action around a specific area that we think is a linchpin across healthcare and public health collaboration. And this year it was actually on community health workers, which I've already spoken to as such an important connective tissue for our health system. It's been really heartening to see the response to this, because I think a lot of folks, either on both sides, if you're in clinical practice, you sort of know that so much of what we need to do for our patients' health extends beyond our exam rooms. But then vice versa, public health organizations know that clinicians are the tip of the spear for the strategies that they're trying to organize, to advance health at the community level. So that's a little bit about the coalition. And I'll just briefly, talk about the Health and Political Economy Project as well, which is more on the medium to long-term end of the spectrum, but which, fundamentally is recognizing the reality that so much of health and illness for the people we serve is downstream of our economy, and is And our economy, of course, is intertwined with our political system. And so that's where, this notion of political economy intersects with health. I have the privilege of co-chairing this with my colleague Derek Hamilton, who is an economist. And the project really started because he and I were kind of obsessing over our respective questions in our fields that we found very both troubling but also motivating to take on. So for Derek, it was, what is the purpose of an economy? Which sounds like such a common sense question, but how many economists have you actually heard asking that question? Derek has a very well-developed thesis about what the purpose of an economy is in a way that is rooted in investing in people and the environments that we live in. And then for my part, I was wrestling with this question around our stagnating life expectancy in the United States. And, the fact that we celebrate far fewer what I think of as healthy birthdays than our peer nations do, for the people who are living in them. So the data point that I think summarizes this most succinctly is that the average American spends only a single birthday in good health past traditional retirement age. So what that means is that, our health span in the United States is about 66 years, whereas in our peer countries, it is regularly above 70 years of age. And when I think about my patients, but also myself, my parents, my children, what do I most want for them? And it's healthy birthdays. It's being able to enjoy a dignified and ideally a flourishing life, in good health. And so I was wrestling with this idea that we ought to be doing far better than we are with respect to the healthy birthdays that get celebrated in our country. And so Derek and I came together and we realized that really, our questions were kind of oriented around something very similar, because so much of what holds us back with respect to healthy birthdays is around how we organize our political economy. And then vice versa, health is absolutely a core part of what the purpose of an economy should be, although is not yet. And so we've really derived inspiration from a number of movements in other fields, for example, in climate or law, where there have been challenges to what is sometimes called the neoliberal economic paradigm, to say there's got to be a better way, to be able to take on climate change, or, for us to address monopoly or other types of aggregated corporate power. And to say that this needs to come into the health sphere as well. I'll just say one more thing about this before taking another pause, which is that, sometimes we talk about this in the context of the social determinants of health. And I've been a proponent of that. I believe in addressing my patients' social needs as well as, the notion of social determinants writ large. But I find that too often those conversations have suffered from what I think of as downstream drift. Instead of asking these fundamental questions, like why are so many of our patients homeless in the first place, we develop systems around making sure that we reduce harm for people who are experiencing homelessness. My clinical practice at Bellevue Hospital focuses on people who are homeless right now, and I think that's critically important for being able to, just help take care of people. But at the same time, we need to arc back to those more fundamental questions about why do so many of our patients suffer from these social and economic ills, and how do we get closer to taking on the core of those problems rather than just patching them up downstream.
Yeah, absolutely. That is so beautifully articulated. I love it. And what I like most about both of these initiatives you just described are they both really focus on like collaboration and partnership. So I want to take them both one at a time. I've got some questions about each of them. Let's start with the Common Health Coalition, because I'm trying to imagine the initial conversations you must have had with all of these different stakeholders. which sometimes it could be described as like strange bedfellows between like public health and industry and like massive healthcare systems. Were there any unanticipated challenges in gathering those voices together in one space? And like, if you did receive any pushback, like how did you respond to it?
Yeah, great question. And you're right. In many ways, it is strange bedfellows. In many of our sort of health policy debates, different groups will find themselves on different sides of a particular issue. But what we found was that there was this like missed opportunity in the convergence that does exist, across those different aspects of health. And it sounds like so common sense, but it is health itself. It is the idea that everyone, although from a slightly different vantage point, and yes, with competing priorities, but ultimately, if you were to ask anyone in any of those sectors, the vast majority of people will have gotten into that work in order to improve health. And so we found that there was this open lane, with respect to trying to build around that. And like, I don't want to come across as Pollyanna. We're not gonna solve all of the very sort of deep-seated problems that exist in how our healthcare system is organized. The financialization and the profit motive that, of course, is something that sets us back with respect to so many of our health debates. But there there is some low-hanging fruit, and there are things that, as I said, we should have been doing yesterday with respect to being able to come together. And the work that we've done on vaccination this year is a great example of that. The Common Health Challenge on community health workers is another example. And I can give a couple of more just for what it's worth. We use this acronym called CARE, which is the strategic framework for all of the activities of the coalition. So CARE stands for C is coordination across healthcare and public health. Just the idea that, we need to formalize the relationships across hospital system and the public health department. Right now, so many of those relationships, and I've lived this for the last 15 years, are basically like, oh, I know so-and-so, let me pick up the phone and, reach out to them. And we need to build more formal mechanisms of collaboration, memoranda of understanding, data sharing agreements to turnover proof those relationships. So that's the C. The A is always on emergency preparedness. The idea that we all need to be reading off of the same sheet of music when it comes to being prepared for a health crisis. Again, I lived this during the COVID-19 pandemic, and I can tell you, everyone had their own emergency plan. They were just all different. And so, how do we actually sync those up, ideally during peacetime, so that we're more ready to work together, when the next crisis hits? R is about real-time disease detection, and E is about exchange of data in a way that is swift, consistent, and actionable. So both of these taken together are really about how we transmit information across systems and to dissolve the silos so that, for example, when when I was the health commissioner, we had a definition for a measles outbreak. It was 3 linked cases of measles. But how quickly you're able to designate something a measles outbreak depends on when that case gets reported, ideally electronically, right? And then how quickly you're able to deploy people to figure out whether or not they're linked or not. And all of that requires a touch point and synergy across healthcare and public health. And we should be doing it not just for infectious diseases like measles, but also chronic diseases as well. So there's ample area of consensus and opportunity, even as there are always going to be points of disagreement, within a coalition as well.
Thank you. And just a reminder to everyone, I've got 1 or 2 more questions left, but if you have any questions, you can submit them in our Q&A. We've already got a couple lined up, and don't worry, I'm going to get to them. So if you have more questions, please keep typing things in, and we'll get to it in just a minute. I want to shift now to the Health and Political Economy Project, which you talked about already as well, and you also kind of alluded to the financialization of healthcare, which is something that group kind of critiques directly. Um, a lot of these are like very like big political and economic ideas, and I'm wondering in your mind what it looks like for a doctor or for someone, a community health worker, someone who's engaging with a patient directly, to advocate for public investment in like health infrastructure. How do we kind of tackle these like big lofty ideological concepts when you're kind of just like a single person working in a clinic, working directly with a patient?
Yeah, a really thoughtful question. Thank you. And I think there are two ways that come to mind. One is to just find common cause. And again, this is what DFA does so well, right? To be able to link people together so that what feels like an insurmountable problem becomes a bit more soluble, if only because, you can reach out to someone and say, "Hey, this is really crazy, isn't it?" And the response is, "Yes, that is crazy, and maybe we should do something about it." And just to get the ball rolling, on that type of dialogue. And so, we're trying to create some dialogue along those lines as well through the Health and Political Economy Project, to do it in a way that taps into uh, what I think of as like latent natural resources in terms of power. So, for example, nurses unions, have tremendous power with respect to bargaining for, the things that they really care about. And nurses unions, frankly, have been a more powerful force toward things like single payer healthcare and, some of the other advocacy priorities that I suspect this group will agree with. And so figuring out how can we further, empower those untapped sources and link them up. And then to do so in a way that also finds common cause with people who are seeking to shift those broader political economic ideas in other fields. So there's a law and political economy project. We had someone write an article for the article series that we just did in Health Affairs Scholar, who drew lessons from the climate movement over the last 10 years and, brought them to what we should be doing, to help organize in health. That was an article by Elizabeth Pop Berman, which if someone can find it easily, maybe we can pop that in the chat as well. So anyway, so that's one aspect of it. But then the other one that I think is even more tangible to your question, Christine, is around just the idea of starting where you are. Each of us has some locus of influence, whether it is our family or our clinic, and figuring out what we can do to challenge some of the narratives that take hold in a way that they almost become a common sense. They become the water that we swim in. Like, the notion that we have 100% faith in markets and 0% faith in government. And finding ways to tell stories that countermand, those narratives and build a different kind of common sense going forward. I think doctors' voices are so important to do this because we can operate on a different plane of credibility than a lot of these political arguments often operate on. And we can speak from the direct experience of serving patients and getting to walk a mile in their shoes. And so I do think there's a lot of untapped power in that as well.
Great. I'm going to turn over to the questions that have been submitted, and I'll kind of briefly summarize some of these. So one is from Sarah Mammon. She's talking about the kind of very anti-vaccine rhetoric that we're seeing from the federal government now, and is wondering how can physicians combat these large, a federal institution that doesn't seem to be promoting preventive health, even though largely what we're going after is something that's evidence based. What thoughts do you have on that?
Yeah, thanks, Sarah. This is a really critical question right now, of course, and very problematic. Some of the some of the stances that have been taken that are not supported by evidence, that is extending beyond vaccines now. I'm sure some people saw the announcement from Monday evening around Tylenol during pregnancy, and purported links to autism. And so, look, there's not an easy answer to this. The government wields a huge amount of power, and trust can be um, eliminated very quickly, and damage can also be done very quickly. So I don't want to sugarcoat sort of the challenge that we're facing with this, but I do think that this should serve as motivation, for those of us who do care in science-driven approaches, and who are very worried about what this means with respect to, the tangible health outcomes. One of the things that I've been trying to point out to people is that because some of these things take a bit of time to manifest in the real world, it's important for us to communicate that the reason, for example, that we're seeing measles outbreaks this year is because of the infectious disease dynamics of measles. It transmits so quickly. But in that way, it's a canary in the coal mine for other vaccine preventable diseases for which we're also seeing dipping vaccination rates. I'm thinking about pertussis and polio just as two examples, which have slightly slower infectious disease dynamics, although we're seeing increases in cases of whooping cough as well, of pertussis. But just to be able to communicate things like that so that the sense of urgency that we all feel doesn't come across as alarmist, or paints us as partisan automatically. Like, these are things that people who believe in, the evidence and evidence-based practice, regardless of our political identity, need to start to give voice to. And then the other dimension that comes to mind is I have been heartened by the ways in which we've seen some of the professional societies step up. I'm thinking about the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists in particular. Both of them released recommendations, for example, about COVID-19 vaccination in ways that contravened, some of the federal guidance, but was arguably more evidence-based. I mean, it was more evidence-based. And so I think what we can do is make sure that we're supporting those professional societies in being able to, give voice to an alternative scientific approach, and also to push those societies in certain ways. And again, DFA really comes to mind for me as a group that is willing to push the envelope, both in terms of the approaches, but with respect to the speed that is required. Many of our professional societies, as we know, don't operate with enough urgency and speed. And look, I get it. We need to make sure that we're rigorous, and rigor takes time. But there is a trade-off. If you're not able to pre-bunk, certain misinformation, or provide an alternative way of, assessing what's going on in real time, then you're going to be sidelined and marginalized. And so I think it's our responsibility to make sure that, professional societies in particular are feeling the urgency of this moment, that we're communicating that urgency in particular ways to the public, and also that we meet the moment with swiftness.
Yeah, and I think professional societies feel like a great example of an action that feels very comfortable for a physician to take. That's usually a society that we're probably already engaged with, and feel very comfortable kind of approaching them and discussing things like that. Are there any other examples outside of professional societies? You mentioned like AAP and ACOG. Are there any like state actions or local health department actions you've been seeing sort of in the last few weeks, months, that you're very excited by, that like give you some hope on how we're starting to address some of this misinformation and public trust?
Yes. And there's a lot of good ferment, in different states. Colorado, for example, was one of the states that passed legislation to decouple, some of their vaccination systems from ACIP recommendations and tying it to professional societies recommendations in addition to ACIP. And they did that sort of before all of the drama of the last couple of months played out. So there are ways to anticipate what's coming around the corner and, advocating for sort of state-based solutions to be ready for the challenges that we know are going to be ahead of us. We've also seen the Western States Alliance and the Northeast, Public Health Collaborative to be able to band together across states with an initial focus on vaccination. But I'm going to be excited to follow, how else they see their remit with respect to advancing sound public health guidance. And look, we need to make sure that these are things that take root, not just in blue states, but also in red and purple states. And I think that's a place where DFA, again, plays a really important role. I grew up in Louisiana. I have family members who live in Texas, and the life of our fellow Americans who live in those states is just as important as those of us here in New York. It's more challenging because of the political dynamics, but arguably even more important, for physicians' voices to help shape that dialogue as a result. And so, that's an area where I'm going to keep looking for strong leaders to step up to the really significant challenges that we're facing right now.
Absolutely. We've got a couple more questions in the chat. And as a reminder, for those who are joining, please send any questions you have into the Q&A so we can make sure they get answered. This next one is from Kenneth Thompson, who talks about, appreciating your efforts to resist American tendency to individualize the social drivers of health and move more upstream. And their question is, do you have thoughts about how we might introduce a health in all policy approach to our thinking in the United States, and how that might bring ideas to politics and the economy?
Thanks. This is such a thoughtful question as well. Thank you, Kenneth. Look, I'll just start by sharing the story. When I had the chance to serve as health commissioner for the city, I'll admit I didn't love the health in all policies framing, and I'll just put my cards on the table as to why. Although, of course, I believe in the importance of the spirit behind it. But, I just thought of it as if, as the health commissioner, I would go over to the transportation commissioner and say, hey, you should really do X and Y because this is part of a health in all policies approach. The transportation commissioner would say back to me, well, I think you should do, A and B because this is really a transportation in all policies approach, and I just say it a little bit tongue in cheek to invoke the idea that health is important. And I do think it is very fundamental to human dignity in the ways that we've already talked about. And I think we have to be very savvy as advocates for health to help other people solve problems using the lens that they already have, and so, from that example, for us to, advocate for bike lanes or greenscaping or making physical activity, a little bit easier in an urban landscape, which is really important for health outcomes, but which probably the right way to talk about with a city planner or, a transportation leader is to think about how it helps solve the things that they're solving for as well. There's a great example from Philadelphia about this. So I don't know how many people followed, but in New York City, in the tail end of the Bloomberg administration, there was the big sodas ban, right? And it was a big deal. People talked about, the nanny state under Bloomberg and, all of this. And basically it ended up being overturned. It didn't, actually become policy. And, part of what they had wanted to do was also pass a soda tax around that time. Well, the same person, Tom Farley, who was the New York City Health Commissioner at that time, who was advancing all of these, creative policy approaches around sugary drinks, then became the Philadelphia Health Commissioner. And in Philadelphia, the mayor was also very pro some of these creative approaches to sugary drinks and improving nutrition, but they never talked about it as a soda ban or a soda tax. They just taxed sodas in order to fund preschool. And so they talked about this as an educational initiative and not as a health initiative. But of course, it achieved the same ends, right? So, anyway, that's just another example of how I think we need to be savvy in our framing and sort of read the politics in a way that helps us achieve what we want to achieve. Um, so yeah, those are the things that come to mind in response to that question.
We've run out of audience Q&A, so I'm going to go off script. And I feel like we've been very heavy, and we've been talking about your time as health commissioner, talking about kind of being in the throes of COVID and, fighting to get vaccines done and like working against like public mistrust. I'm wondering I want to keep it kind of light now. What were some fun, like what were your most fun parts of being health commissioner? What were things that you got to do in that role that you don't get to do anymore? The things that kind of brought you a lot of joy when you had that position.
Yeah. Thanks for asking that question. Not one that I usually get. I mean, it was a pretty challenging time for all the reasons that you said. But well, look, the coolest part of my job, serving as health commissioner, is that I got to have my signature on all of the birth certificates. So for those 2 years when I was serving as commissioner, like it was my signature on the birth certificate for every new baby that was born in New York City. And I'm so proud of that. And I do think it connects to, that notion of healthy birthdays. Like we should really take seriously our job in health as being the people who certify, the birthdays, as it were. And I thought that was such a beautiful symbol of, of how I got to do that. And then, yeah, I mean, we made some progress on other initiatives. You mentioned the Board of Health resolution on racism as a public health crisis, which was a chance for creativity, and then opening up the first two overdose prevention centers that were publicly authorized in the United States. And those were things that, you know, I I think may not have happened were it not for the pandemic. So, there were ways that we took advantage of the attention on health and the health department to be able to make progress in other arenas as well. And I guess I'll just end on the personal note on this, to say that uh, I have two young daughters. One of them was born just before the pandemic, and then the other one just a couple of years ago. And uh, I think all of us should think about how our jobs are essentially to build better futures for our kids and the other kids, in our communities. And so even when I was uh, tired down to, my bones, that was part of what motivated me and kept me going.
I think that is probably the same for a lot of us who are listening now. Well, I kind of can't think of a better hopeful note to end on. So I know everyone's sort of taking time away from their lunch break to listen in on this discussion, which I really appreciate. So we'll put a little bit of time back in everyone's day. And as a reminder, if anyone wants to revisit any of the discussion today, this is available recorded, so you can check out the DFA website to get more information, and all of the links we shared earlier. Please make sure you click on those and save them with some open tabs, so you can go back and revisit those later when you have some time. Well, Dave, thank you so much again for your time today. This conversation was really fantastic and has left me feeling very uplifted and hopeful in what has otherwise been some pretty dark times. So I appreciate that. And to everyone else, I hope you all have a great rest of your afternoon. Thank you so much for joining us.